make this a conversation, so I will sit and Bert will take questions directly from you guys.
Dr. Garza.
Hi, Susan. Or is it Dr. Robert?
So I love this kind of philosophical approach, and I would personally love to see some way to, bring the process of reviewing the dietary guidelines and the DRIs closer together, especially for chronic diseases. I mean, I think that makes a huge sense. But the conversation I wanted to kind of put out there really is that there's a lot of hidden assumptions in the dietary guidelines and also the DRIs that, we almost take for granted now, and I wonder whether they should be part of these big picture thinking. And I'm thinking, for example, the 2 standard deviations above the mean for the nutritional requirements, because that has enormous implications for the dietary guidelines. It means that 98% of people are going to be adequately covered with that intake, but it also means many people are going to be eating more than they actually need. That has implications for how many servings of fruits and vegetables you recommend. I mean, it has enormous implications for both sides. So, how deep into this, philosophical approach are you going to go?
Well, remember that in fact, if you're planning for groups, using the RDA the way you just said is wrong. It's just incorrect. And so that in fact, if dietary guidelines is being based on the RDA when you're thinking about feeding a group, then that was pretty much debunked 15 years ago. If you're giving dietary guidance to the individual, and that's the level of comfort you want, is a 2% risk of deficiency, then yeah, that's what you've got.
But I think in most cases, people, those numbers, which are means plus 2 standard deviations, are kind of out there.
Well, and that's an educational issue. That's something that, in fact, we as a scientific community need to do a much better job of. And it's not just, it really is sad because it's not just the lay public. I mean, I just had a discussion with a group, an international group, yesterday, that in fact was planning diets for groups based on RDAs 15 years after the fact. So it continues to haunt us. I do think there are ways to deal with it, but it does require, I think, a much more concerted effort at helping people get it right. And I don't disagree with you that that's what is out there, but it's wrong.
Dr. Garza, so you mentioned you like the personalized medicine kind of approach, and you mentioned also that the GWAS studies have not been really, very good at finding solutions per se. Given the amount of resource that goes into GWAS studies, would you instead support an emphasis on EWAS studies, the environmental wide, rather than the GWAS?
I think one has to go to both. There was and I'm forgetting the first author's name, a very interesting report just about a month ago in the New England Journal trying to do just that, looking at lifestyle and genomics and diet and cardiovascular disease. And I think that that's the approach that we have to take. I do think that there may be in the future, not next week, and not possibly even in 5 years, but certainly within, I think, within the foreseeable future, software applicable ways to be able to deal with an EWAS type of approach and provide that level of precision with the guidance of expert groups that develop the dietary guidelines and the DRIs together. Understanding the environmental and genetic and other, environmental and other diet related changes, yeah. But you're right, it should be EWAS. Yeah, especially for that because of the complex etiology. More difficult from my perspective, is how we deal with a longitudinal issue. Because a key assumption that I always make, and maybe it's a false one, is that whatever health you have in your present life stage is the consequence of what you've done not only in the present, but in the previous life stage. And so you have to be able to follow these things longitudinally in ways that I don't think we're quite prepared to do. And how we do it while protecting people's privacy will present some real challenges. but they're challenges that are solvable. And the example that I often give is if you look at system science and what they've done with the weather, if something as complex as global weather systems can be modeled, then I do think there's hope for our being able to model at least the impact of diet on individual human health.
Hi, Bert. Thanks for some thoughtful comments. I think one of the criticisms that we constantly hear about the DRI approach is that it's a reductionist approach. And yet, when it comes to chronic disease risk, when it comes to dietary guidelines, a reductionist approach usually doesn't get us in the right place. So I'd be interested in hearing your comments around that concern.
Well, our group discussed that. Maybe not as frontally as you just described, Barbara, but you are correct. I think that a reductionist approach is correct if you're dealing with a deficiency disease. It doesn't work as well or at all if you're dealing with a chronic disease. And the report lists two options. This group could come up with others in terms of dealing with that. And that is that rather than taking a nutrient-based approach, that one take a chronic disease-based approach. And say, we're going to develop DRIs for successfully dealing with hypertension, cardiovascular or other cardiovascular disease, diabetes, and that in fact, depending on that individual's risk profile, they may want a DRI or set of DRIs that relate to that particular condition at which they're most at risk. Now, that makes things much more difficult for the health provider and for the individual, because we're suggesting that one option that ought to be on the table is that greater flexibility and choice. But it does change the framework. And we were not even sure in those discussions that it made any sense to keep to the mean plus 2 standard deviation model for that. But we left it up to groups like this that are much wiser than and have more time, we hope.
Just to maybe add another dimension to that, you referred to the non-essential nutrients, and I always wonder...
Or food substances, yes, I correct.
Yeah, food substances, whatever we're going to call them. But I wonder if that reductionist approach is also what complicates our ability to understand how they fit into the whole equation.
Yeah, and that's why we thought that one option that ought to be on the table is the one I just mentioned, because that would enable you to look at a constellation of food substances, some essential, some not, that related to the specific chronic disease you had in mind or were targeting. Yeah. But I, at least, again, to the degree that we came to any consensus, I don't think the group thought of keeping the same framework we had or have had. And one of the issues was that reductionist approaches will not work. Because often you can achieve the same relative risk reduction in multiple ways, diet just being one of several.
Yes.
Hi, Susan.
Sue Crooksmith. So building on that, I'm wondering whether you could talk a little bit more about how you see the difference between the task for developing the DRIs versus the task for coming up with the dietary guidelines, or at least the Dietary Guidelines Advisory Committee report. You were saying that you thought that the DRIs are really essential and have been for previous reports, because up to now they've been dealing with the deficiency diseases. So now if they're focusing on chronic disease, and if they're going to be maybe more integrated and not so reductionist nutrient by nutrient, then how do you see the complementary roles of these two things?
I think that we still have to deal with deficiency diseases. It isn't as if scurvy can't reappear. We don't continue providing vitamin C in the ways that we do. And so to the degree that dietary guidance is provided in the future, then we always have to test those dietary patterns against those deficiency diseases, so that a set of DRIs that deals with deficiency diseases, I think, are essential. Now, once we get into the chronic disease arena, I'm not certain that you can come up, but I'm thinking out loud with you, with a single dietary pattern for all chronic diseases. There's some similarities that I think are going to play out, but it's still too early, at least for me, to say that once we understand those relationships better, that if I'm primarily interested in cancer or in cardiovascular disease or diabetes, that it's going to be the same pattern, that it's going to give me maximum protection. Maybe that's the case, but I wouldn't think so. You may want to have 3 or 4 diets, again, fitted to that individual's not only a disease profile, risk profile, but their preferences, and be able to take the DRIs that were developed, make sure that in fact you're not going to create any deficiencies, and then see if they achieve the levels of risk reduction, relative risk reduction that you're targeting. So I do think there's ways to do it, but it isn't going to be a single pattern or a single set of DRIs.
Thank you. Thank you very much, Dr. Garza. Thank you.